Okay, specific learning disorders. This is a child who has difficulties learning and using academic skills. Learning and using academic skills, usually persisting for over 6 months despite treatment. If it's in reading, it's often labeled as dyslexia. They have difficulties with word accuracy, rate, or fluency. It could be in writing, or it could be in mathematics, which is labeled dyscalculia. They have issues with number sense, memorization of arithmetic facts, accurate or fluent calculations, or accurate math reasoning. In writing, it could be issues with accurately spelling words, grammatical formations in sentences, or just the clarity of their written work. I guess, should I look back at some of my earlier writings, I could say I probably had a few deficits there, but then it has to go on for over 6 months. And despite interventions, it cannot, or it is not corrected. It becomes a specific learning disorder if the child is functioning below expectations for age, or if it causes significant interference with their function. A lot of kids with ADHD, you'll notice that they have like 504s or plans in place to help them to work through the school setting. And what this does is, according to the Americans with Disabilities Association, they put accommodations in place so this child functions better in the academic setting. What are some accommodations you think you might see for a child? Extra time on tests, yes. Smaller classrooms, so it cuts back on the overstimulation sometimes. A different test setting, fewer distractions, more one-on-one. Sometimes they'll even have a one-to-one person working with them, somebody who can sit with them and help them to refocus. So definitely, those are a lot of accommodations you would see. Sarah, as I was going through the questions, I was looking for my drug book. You had asked that it's counterproductive to give the stimulant to someone who's hyperactive. Yes, and I alluded to it acting on the neurotransmitters in the body, and pretty much what I said, that it increases norepinephrine and other dopamine actions, blocking their reuptake. It can enhance dopamine or norepinephrine actions in certain areas of the brain, which improves attention and concentration. It enhances dopamine actions in other regions of the brain, like the basal ganglia, which also may improve hyperactivity. It enhances dopamine and norepinephrine in other areas of the brain regions as well that can improve fatigue or sleepiness. So sometimes you'll even see them being prescribed for patients with sleep disorders as well. So it works in those neurotransmitters, notably dopamine and norepinephrine. You are welcome. Developmental coordination disorder. This is an acquisition and execution of coordinated motor skills that is substantially below what is expected for age. So at a certain age, you're expected to jump, skip, hop, walk. So this child will have difficulties in doing what is expected for their age. So they'll have symptoms of clumsiness, slowness, or inaccuracy in performing what is deemed to be normal skills. The symptoms will significantly interfere with ADLs in the family, school, socially, or in the community. Usually not diagnosed before age 5, because you can think a child from 1 to 4, it's kind of normal for them to be klutzy and clumsy and falling over, tripping over their own feet. So that's normal stuff. It involves motor skills, not due to medical or neurological conditions, or any distractibility disorder. Stereotypical movement disorder. This is repetitive or seemingly driven and apparently purposeless motor behavior. So this child will have hand shaking, waving, body rocking, self-biting, just this constant stereotypical movement. Whatever it is, it's kind of motion in a stereotypical way. It'll interfere with your social, academic, and or other activities. Again, usually presents before age 3 and may result in self-injury. Stereotypical movement disorder. Sometimes, like you see a lot of children with intellectual disabilities, you'll see them doing like either hand movements or head movements. It's pretty common that you see those going hand in hand. A tic disorder. A tic is a brief, non-purposeful movement or vocalizations. It could be movements of the face, neck, shoulders, muscles, limbs, any part of the body. So it's non-purposeful movements or vocalizations. So it could be would you like some water? Is there something in your throat? No, I'm okay. So that could be a tic. It could be sniffing or grunting. There could be palilalia, and this is repeating their words or their phrases. Like, can I have some water? Water, can I have water? Can I have some water? Echolalia, repeating the last words or phrases, repeating the last words or phrases that they hear from somebody else. It could also be corporalia, which is where you'll find the patient uttering socially unacceptable words. So in the midst of your assessment, well, my day was shit. Damn. So corporalia, those are tics. It could be vocal as well as it could be motor. So that is a tic disorder. Then we move on to a Tourette's disorder. So tic is either motor or vocal. Tourette's is both motor and vocal tics. These types of tics are seen in children. So the types of tics I'll list here are the ones that are seen in children with Tourette's disorder. They could be simple. So it can be short, motor or vocal, clonic, jerking, or slow or long-lasting. So movements can be quick, like just constantly making that movement. It could be complex tics, which is more complicated, coordinated movements. I have a patient, he has an intellectual disability, resides in a group home, and he does have a tics. And the entire time he's sitting in the office, he has a huge routine that he does with his hands, repeatedly going over his head, coming back, touching his shoulders, and it's just his movement. And those he has a Tourette's disorder, and he grunts the entire time he's there as well. The tics could be vocal tics. They could be sounds from the throat, such as the grunting or the sniffing, the nasopharyngeal, or just barking, sniffing sounds or syllables. So key point to take away, tic, one or the other, Tourette's, a combination of both. Disruptive impulse control and conduct disorders. Now, this is where I see most of my patients residing, my adolescent patients anyway. We have the oppositional defiant disorder. So this child will have a pattern of angry or irritable moods. They'll be argumentative, defiant even. It can be very vindictive, and this goes on for a period of at least 6 months. So if little Johnny just got upset with you and he was very argumentative or angry just a few times here and there, no, this is a child. It's a pattern of behavior. That's how they are. They often lose their temper. They're easily annoyed or even angry and resentful. Very often you'll find that they have issues with authority figures, do not follow rules, and often deliberately annoys others. And then they will blame others, say, he started it, it was his fault why I did this. This is a child you probably see engaging in vindictive behaviors, very spiteful. They are out to get you. They'll tend to run away or be resistant to change. So it could be a divorce, it could be a move, a change in school, but they will definitely show their dislike for whatever is happening around them. It causes significant distress to both themselves as well as those around them. I can tell you I've dealt with many parents who have had to deal with kids with these disorders, and it is draining, as it is for teachers, as it is for their friends. It is a lot to deal with or handle. The symptoms are at least once weekly for a period of at least 6 months. So it has to be ongoing for at least 6 months, at least one weekly. Oppositional defiant disorder. So this is little Johnny who just doesn't listen, but it's more than just doesn't listen. This child has a pervasive, this is their baseline behavior. Then you have disruptive mood dysregulation disorder. This is severe recurrent temper outbursts, verbal or behavioral, grossly out of proportion to the situation at hand. So this is, could you be saying, Johnny, can you put the orange juice back in the fridge that you left on the counter? And he goes in there, smashes the jug, slams the fridge, kicks the dog, and you're like, what is going on here? So the temper outbursts are inconsistent with their developmental level. They occurs on average 3 or more times a week, lasting for over a year, occurs at least in 2 or 3 settings, because if he's only throwing this fit at home, maybe you need to examine your parenting. But if he goes to school and teachers are complaining, when he goes to karate, the karate instructor is complaining, then we have a disorder going on. There's something else going on here. So even when little Johnny is not having these outbursts, his mood between these outbursts is angry or irritable. So his resting phase is irritable and angry. Usually an onset before age 10. There are higher rates in males before the high school years. DMDD, Disruptive Mood Dysregulation Disorder. And we have IED. And when you think of an IED, you think of something blowing up, right? So intermittent explosive disorder. It's a recurrent behavioral pattern that or outbursts presenting a failure to control aggressive impulses. So they get pretty angry and they cannot control this anger. I have a few adults with this disorder. They will have verbal aggression, temper tantrums, triads, aggression to others, or damage to property. What do you think triads are? Think of triads, think of triangles and relationships. So this is the child who will tend to pit others against each other. There's them, there's mom, there's dad, and he's saying mom told him dad said he could do this, and dad said he couldn't do that because you're talking to mom. So they form triads, and usually there's a lot of discord where triads are formed. Their aggression, again, is usually grossly, yes, they are. Aggression is usually grossly out of proportion to the situation at hand, usually resulting from a minor provocation, usually not premeditated and not related to intimidation or other such goals. So this is not someone who's trying to bully. This is someone who has an issue with being angry and irritable and having outbursts. So they're not doing it to be a bully or to intimidate others. This is just who they are. This patient must be at least 6 years of age, and outbursts typically last under 30 minutes. Then we have a conduct disorder. This is a persistent pattern of behaviors in which the basic rights of others and the rules of society are totally violated. So this child has no regard for anybody or anything. Their behaviors are in 4 major areas. It could be aggression to people or animals. It could be destruction of property. It could be deceitfulness or theft. Or there could be a serious violation of rules. So if they have no regard for anybody or anything, they are just, it's like, it's whatever. This causes significant impairment in social, academic, as well as occupational functioning. This child usually has a lack of empathy. So along with their it's whatever attitude, they don't give up about anything either. There's a lack of remorse. They have a shallow affect. Yeah, I'm so sorry. And seem totally unconcerned. As this child ages, this disorder becomes an antisocial personality disorder in adulthood. So over age 18, and you need to know that, it becomes an antisocial personality disorder. So should this child present with these behaviors in adulthood, where do you think they're going to end up?
Jail?
In jail, certainly. As the child ages, they become age 18, it's no longer labeled, because I'm sure you can think of some adults with these behaviors, but you wouldn't find an adult with the label of a conduct disorder. That adult would become someone with an antisocial personality disorder. You know how people like to go around, oh, I'm so antisocial. Just be careful of the labels you're giving yourself, because that's not what antisocial means. An antisocial personality disorder is an adult with these behaviors. I have 2 patients with an antisocial personality disorder. So stimulants, we mentioned Adderall, Dexedrine, Ritalin, methylphenidate or methylene. Usually not recommended for those patients under age 6 years of age. Long-term use, as I mentioned before, can be addictive or lead to tolerance, and this is why a lot of parents are very apprehensive about starting their kids on these medications, because they know of their addictive properties. Should be taken 30 to 45 minutes before a meal. Does anybody have an idea why? I think that's a very educated, yes. Absorption, loss of appetite. A major side effect from stimulants is the loss of an appetite. So a lot of kids who take stimulants, sometimes they will look smaller than their stated age. They will look underweight because once they take that pill, they're good for the day. They don't want anything to eat. Not all kids, but that's what it affects some kids. And that's why sometimes kids will take drug holidays where they don't take them on the weekends, or they don't take them during school vacations to give them a chance to catch up on their growth. Side effects: decreased appetite, weight loss, difficulty falling or staying asleep. And this is why it's not prescribed later on in the evening, because it has potential, well, it most certainly will keep you awake. It's recommended that you avoid it in use in kids with family with tics or Tourette's because it worsens those symptoms. Avoid caffeine with all stimulants. Why? Caffeine is in itself a stimulant. Thank you. A lot of people don't know that. That's why when I assess my patients, I'm like, any drugs, any alcohol, any cigarettes, any caffeine, and they're like, coffee, like something as simple as coffee. Yes, coffee is a stimulant. So when you're telling me you're drinking 5-6 cups of coffee daily and you're restless and you're anxious and you can't sit still, you feel like your heart is pounding in your chest, lay off the coffee. We're going to look at antidepressants. As the name states, antidepressants are used to treat depressive disorders. Not just depressive disorders, most of them treat anxiety disorders, panic attacks, PTSD, so they treat a little more than just depression. So the first line class of drugs means you go to someone who's prescribing for you and you say to them, I have anxiety. The first class of drugs they will typically reach for is SSRIs. That's your selective serotonin reuptake inhibitors. And that's your Prozac, Paxil, Lexapro, Celexa. So those are the run-of-the-mill drugs that you'll see prescribed very frequently. So you're working on the floor, you see a patient with these meds prescribed, that should give you like a haha. They are here for a stomachache, but you're taking an antidepressant, so they probably have some anxiety, some depression, some PTSD, something going on there. So just to familiarize you with the drugs, these are they. Advantages is they are used to treat many disorders, as I mentioned, not just depression. And they're very, very widely prescribed. Disadvantages to SSRI is some cause weight gain. A very popular one I get from patients. A very popular one I get from patients is decreased libido. Like they'll come to me and they'll say, I'll start them on the drug. And someone's microphone on. I usually ask the patient, I usually tell the patients of the side effects, just so when they start having the symptoms, they don't stop taking the drug. So I kind of prepare them for what may happen. And very often, this is what happens very often, the drug will be working, they're happy with how they feel, whether it's anxiety or depression, they feel that drug is working. And they're like, what? I've noticed that I'm not as interested in sex like I used to, or I'm having a hard time getting an erection. And sometimes they're very embarrassed to say this because it's a very personal thing. And I'm like, no, that is a side effect of the drug. And I'd ask, so let us change that drug. And they're like, no, because the drug is working. I'm like, no, I think you should change the drug because while you want to treat your depression and anxiety, you don't want to create a new issue because then that's going to cause a problem in of itself where either you can't get an erection or you're not interested in sex. It's going to affect your relationships. So very often we'll change the drug, even though a lot of them have that side effect, they don't all affect the patient the same way. Another side effect is that they may cause a neuroleptic malignant syndrome. A neuroleptic malignant syndrome, well, if used with MAOIs, that's the monoamine oxidase inhibitor drugs. If they're used with MAOIs, they can cause a neuroleptic malignant syndrome. Another drug, and as I'm talking about neuroleptic malignant syndrome, it's something you need to know. Another drug that causes NMS are antipsychotics. That's a side effect of antipsychotics as well. And one mnemonic I usually use for it, I guess we'll probably, it's the next slide. So I'll discuss this in a little, neuroleptic malignant syndrome. SSRI use can also cause a serotonin syndrome, where they can have increased blood pressure, increased heart rate, lots of different things going on while they're using the drugs. Sometimes they'll be on different serotonergic substances, and that's why as their nurse, you need to look at what they're taking, look at the symptoms that are presenting in front of you, and choose to target those symptoms. Neuroleptic malignant syndrome. This is where the patient has used a drug that has caused an onset of it. They can have decreased level of consciousness, maybe even stupor, increased muscle rigidity, fever, hypertension, changes in blood pressure. It could be tachycardia, changes in their heart rhythm, sweating. One mnemonic that I use, and did I give it to you here? It is hot, stiff, and out of it. Anyone reason through that for me? Yes, yes. Hot, stiff, and out of it. And that's one thing I've used through school, through my boards. Hot, so you walk into a patient's room, temperatures increase, they're laying in bed pretty rigid, decreased level of consciousness. What do you suspect? Neuroleptic malignant syndrome. Know the indications or diagnosis of a neuroleptic malignant syndrome. Serotonin syndrome, it could be confusion. Hypomania. What do you think hypomania is? So it's not quite a full-blown manic episode. A lot of people are walking around in a hypomanic state where they can have the increased speech, increased goal-directed activity, some paranoia, some hallucinations, delusions. So serotonin syndrome can cause a hypomanic state. They're restless, sweating, shivering, diarrhea. So just know that drugs, antidepressants, SSRIs, they can cause serotonin syndromes. I had mentioned MAOI, monoamine oxidase inhibitor drugs. That's the Nardil-Parnate, the Marplan. You'll see those prescribed as well. They are the second line of treatment for depression and anxiety, which means, say the patient has taken a class of drugs from the SSRIs and they did a trial of maybe 3-4 of those drugs and they didn't work, then the prescriber will change to a different class of drugs. And it's important to educate the patients when they take these drugs, the MAOIs, that they must taper the drug. They can't just stop taking the drug because then they're going to have withdrawal symptoms. There are also dietary restrictions for MAOI drugs, which if not followed can lead to headaches, chest pain, serious increase in their blood pressure, leading to a hypertensive crisis. So education is key. What are the foods to avoid? Deli meat, cheese, aged cheese, beans, yeast, chocolate, excessive chocolate, pickled fermented food, like a lot of those cured foods, grapefruit, cherry. So there's a long list. So if the patient is taking an MAOI drug, the Nardil, the Parnate, the Marplan, you want to just have some insight that it's the MAOI. I should teach my patient about the dietary restrictions. There are some foods they can have, but in moderation, such as the cottage and cream cheese, yogurt, spinach, raisins, tomatoes, coffee, beer, ale, wine. I must say this is not a class of drugs I prescribe very frequently, but it is used. Then there's also the tricyclic antidepressants. So these are also antidepressants which you will see patients on, because sometimes because of the side effects or for lots of different reasons, they'll take an antidepressant from a different class. So the tricyclics, the Elavil, the Senequa, the Remron, the Anafranil. So those are very common ones you'll see prescribed. The target symptoms are the same as the ones from the SSRI group, just that they come from a different class. Compliance with taking the drug, yes. And this is why you educate the patient. So usually when you choose a drug, you choose a class, you educate the patients about the side effects, if there are any restrictions, and this has to be something that they buy into and agree to. So if it is that it's something they have agreed to, then compliance is less of a concern because they understand why you're taking this drug and the need to adhere to these restrictions. And you make sure for instance, make sure I make note, discuss risks, benefits, restrictions with patient express understanding. So make sure you put it all in writing. So should in case you have some adverse reaction from not following, you sure that you are done your duty in educating them. You're welcome. Tricyclics are also a second line of treatment because they have more disadvantages. They can cause an anticholinergic side effects, which are blurred vision, headache, agitation, urinary retention. Yes. So this is why we wouldn't give someone a drug from the tricyclic class first when we know they cannot get all these side effects. So we start with a class of drugs with lower side effects, which is the SSRIs. Not used with many medical conditions. If the patient has glaucoma, any CV issues, pregnancy, it is contraindicated. Anticholinergic side effects. Anticholinergic, such as urinary retention, headaches, blurred vision, agitation. You're welcome. Feeding and eating disorders. This has also become very, very common in the adolescent population. It is still present in adulthood. I do have a few patients with anorexia, bulimia, but it's even more so prevalent with the adolescents. The causes, it's a behavioral and affective disorder associated with eating. Behavioral and affective disorders associated with eating disorders include. So it is saying very often when a patient has an eating or feeding disorder, they also have a behavioral or an affective, which is a mood disorder that is associated, and you should know this. So very often they can have a major depressive disorder. They can have a borderline personality. That's what that BP stands for. They can have anxiety, substance use issues, or personality disorders, which a borderline personality disorder falls on the personality disorder. But I guess borderline was taken out to draw emphasis to is that especially patients who cut and engage in the like bulimia, anorexia behaviors very often have a borderline personality disorder. And we will get into personality disorders as we move forward, so you get a better understanding of them. But just know that very often they're associated with a behavioral or affective disorder, these eating disorders. They're never usually like a standalone. Usually there's more going on. And that is what, and they're called comorbidities. Co, because they're occurring together, comorbid diagnosis, the eating disorder or the affective disorder going together. You should know those. PICA. This is the eating of non-nutritious foods, non-food substances, which are inappropriate for age and developmental levels. So if in my teen years I'm chewing on some crayons, you'd expect to see me doing that back in preschool, not so much in high school. So PICA, it can include paper, soap, hair. There's a huge list of things which could be included in this disorder. You have to make sure that it's not part of any culturally supported or social normal use, because people eat different things in different cultures. You want to make sure you're not making a big fuss about this child chewing on who knows what, because it could be something that's a cultural practice or something that is viewed as normal in their culture. From the eating of these non-food substances, the child could develop medical complications as a result. It can be associated with autism spectrum disorders and intellectual disability. Very often it is. Rumination disorders. This is repeated regurgitation of food, either re-chewed or re-swallowed or spit out. So this person will be chewing. You see they appear to swallow the food, and you see them bringing it back up and chew some more. Usually occurring several times a week, usually daily. Not related to a medical or gastrointestinal disorder. It does not occur exclusively during another eating disorder, and may occur in the context of a mental or developmental disorder. It could be lifetime, this rumination disorder. No, that's different. So with bulimia, they're actually making themselves throw up. With this rumination disorder, they're bringing the food up into their mouths to re-chew. You're welcome. Avoidant restrictive food intake disorder. As the name states, avoided and restricted. It's manifested by the persistent failure to meet appropriate nutritional or energy needs, significant weight loss, nutritional deficiency, dependent on oral nutritional supplements, marked interference with their psychological functioning, usually not cultural or because they don't have food, and it's not associated with concern about body image, not attributed to any other medical condition or mental disorder. I have one patient with this disorder. He is 18 years old, high school senior, and he has an avoidant restrictive food intake. He just has a lot of hang-ups about the textures of food and what he likes, and he very, very, very minimal intake. He is 18 and he probably looks like he is 12. And he gets a feeding tube every night, all night. He's talking about going away to college. I'm sure that's going to present another issue as he realizes that he has to travel now with a nighttime feed. But he's in therapy. He's working through his disorder. The therapist will have the parents bring in like a wide variety of food, and they will try different foods in therapy. But it's something he continues to struggle with. And you're probably saying you're a med for this. Not necessarily, but he does have some anxiety around food and eating food, so he's been treated for anxiety. Then we have, go ahead.
Another question. So in his case, you said, okay, so I'm just reading the slide. It says that he's not so much worried about body image. So it's not like a conscious, I don't want to eat because I'm worried about, body image or anything like that. It's more just, he can't get past like the texture.
Yes.
Is it taste at all? Or is it just like, that look?
For him, so he restricts what he eats totally. It's not the next slide. We're going to talk about anorexia because they're looking into body image and this distorted sense of self. It's none of that. It's just restricting his food for different purposes.
He doesn't have an interest. There's no interest in eating.
Yes, that too.
Okay.
And he gets his nutrition at night, so he's full and he's good with that.
Okay. He doesn't really have to work for it. I mean, and not to be disrespectful, but he gets it, through the tube, and then it's not like another thing he has to worry about. He doesn't have to process the not wanting to eat. It just kind of happens for him.
Do you say if it's a habit?
I'm saying that it, you know, as far as nutrition, it just happens. He doesn't have to process like that action. It's just he's getting the nutrition
Yes.
on its own.
As he goes through life, he needs to work through these issues. Imagine when he becomes an adult and he has a female partner in bed and he's hooked up to a tube all night to get fed, or going away to college, it's going to start presenting more issues as he embarks on adulthood. And like the therapist and I, like we would talk about it, he said the parents need to, well, they're now consulting with a nutritionist, and it's a thought to get him off the nighttime feed so we can get him hungry during the day, and maybe he will then start increasing his PO intake. So we're working on that right now to see how that goes.
Thanks.
Welcome. Then we have anorexia nervosa, which is a little bit more common. This is a restriction of energy intake leading to significantly low body weight in context of age, sex development, or physical health. So this patient will engage in vomiting or diuretic or laxative, will not engage in vomiting or diuretic or laxative use. But I wouldn't say not, but it's usually uncommon. So this is the patient with psychological issues. They have a fear of being fat. They have a disturbed body image. So they will restrict their food because they're of their cognitive distortions. They look in the mirror and they see this when everybody else is. It's sometimes as a means of control. I've come across research studies that show where teens have controlling parents. This is how they chose to control their world, so they control what they eat. It could be for a sense of perfectionism. They want the perfect body, so this is how they will construct it, by restricting what they eat. There are signs and symptoms that go with a patient who has anorexia nervosa. They will have a growth of lanugo, that extra, when babies are born, they have that little hair covering. They can have that, so that can return. They can have cardiac issues, early osteoporosis, hair loss, issues controlling their temperature, amenorrhea, and even death. And it says the death rate here is higher than all other mental illnesses. And you're like, whoa. And I had to say whoa when I learned that at first too, because quite a few young people, even older people who have older patients with anorexia, engage in this behavior. So usually starvation or suicide is how they die, but it is a very serious mental illness, and it is being practiced very, very widely. You should know the physical manifestations of someone with anorexia nervosa. And there's an image there of someone who has a cognitive distortion. That is what she sees, and that is the reality. Bulimia nervosa. This is the recurrent episodes of binge eating, so they're just going to stuff themselves. And then they vomit or use diuretics or laxative. That use is very common after eating. Their self-evaluation is unduly influenced by body shape or size. Weight is usually normal or close to normal. Death is usually through hypokalemia or suicide from the constant purging. There's recurrent compensatory behaviors to prevent weight gain. So they will purge, they will use enemas, they will fast, they will over-exercise. And this is a patient who has bulimia nervosa. Then we have a binge eating disorder. This is the recurrent episode of just eating. But what's different here, this patient is not making themselves vomit. They're not using laxatives, they're not using diuretics, they're just consuming that food. Usually from a lack of self-control. Episodes can include eating more rapidly than usual, feeling uncomfortably full, eating even when they're not hungry, eating when they're alone because they're embarrassed because of how much they eat, or because they feel disgusted with themselves. However, they cannot stop themselves from eating. They will eat and eat and eat. This patient is usually overweight or obese. It occurs at least 1 week or 3 months. It is not associated with any compensator. It means there's no purging, no diuretics, no nothing, no laxative use or anything. So they consume the food and it stays there. Then we have elimination disorders. And as the name states, eliminating. Encoparesis. This is the child who repeatedly passes stool in inappropriate places, whether it's involuntary or intentional. It occurs at least 1 month for 3 months. The age of this child must be younger than 4. I mean, if anyone's been around children, some kids take a little longer to get potty trained, so it's kind of normal if even at age 3, 3.5, you're still not potty trained, you're still pooping in your pants. That's understandable. So after age 4, then it sends a little red flag. Okay, let's look at what's going on here. May be associated with constipation. It's not due to any medical condition or effect of any substance. So if this child is taking laxatives, his mother just likes to give him laxatives, and he's pooping everywhere, then it's not encoparesis. This is a direct effect of the laxative use. It's more common in males, and there may be a familial factor. There's primary and secondary encoparesis. Primary is fecal incontinence in a child that was never previously trained. And secondary, the child was previously trained for a period before they started having these incontinence issues. My friend that has a little boy who has autism, he also has encoparesis, secondary. He was fully potty trained, and now he's not anymore. Enuresis, repeated voiding of urine during the day or night into a bed or clothes, whether involuntary or intentional. At least 2 weeks or 3 months. It usually causes distress or impairment. The age of this child must be at least 5 years. Again, it's more prevalent in males. They may have a familial factor as well. 75% of these children have a first-degree relative who also has this disorder. So there's nocturnal or diurnal, nocturnal, night, and diurnal during the day. So it can be either or. Enuresis. Then we're going to look at anxiety disorders in children. So some children can have, it's okay for children to be anxious. You drop little Johnny off to daycare and he's crying, I want my mom, I want my mom. That's understandable when little Johnny's in pre-K. You drop little Johnny off the first day of high school and he's screaming, I want my mom, then that's not okay. So excessive anxiety, concern, and separation from home or from those to whom the person is attached. And this is not only present in children, this could be adults too. You know, that guy that has that girlfriend, he complains he can't go anywhere without her because she's just so clingy and she gets anxious or so if he doesn't come home. So it could be adults as well. It lasts at least 4 weeks in children and adolescents and 6 months or more in adults. It begins before age 18 and may develop after some light stressor. So very often when I hear about a separation anxiety, it usually happens when there's a divorce in the family or some breakup or some death that affects the child in this manner. It can cause significant distress or persistent impairment. as this person will worry about harm. I have one little girl, and she will go to school, and for every time she likes her teacher repeatedly, can I call home? Can I call home? I just need to talk to my mom, because she's worried about harm occurring to the mom. She's worrying about the things that could cause harm, that could cause them to be separated. She worries about being left alone. This child may have nightmares, hence the difficulties in sleep, school difficulties because they're separated from their loved one and they just can't focus, they can't concentrate because their thoughts are with them or they're constantly worrying, so it affects your ability to sit and learn in the classroom. And this is a child who can have somatic complaints. I worked as a school nurse for 10 years. I can tell you, I definitely knew those kids who would come down, especially on a Monday morning, and they would complain, oh, my stomach hurts. Can you please call my mom? That's because they want to go home. That's because they want to be with their parents. I'm not saying they had a separation anxiety disorder, but those are those somatic complaints that they come down with because to fulfill their need to be close to their loved ones. So excessive anxiety progresses into a separation anxiety disorder. So what are your nursing assessments and/or nursing interventions? Make sure you're aware of the child's level of development. Make sure your expectations are real. Is it okay for a 2-year-old to poop their pants? Is it okay for a 14-year-old to poop their pants? So you want to make sure you're looking at their developmental level. Make sure your communication is appropriate as a nurse working with children. The jargon you'd use for adults would not be the same you use for children. So to your stands, sometimes it will be necessary to get down on their level, to get on the floor and even play or engage with them to get your point across. Look at the family dynamics. Is there a divorce going on? Is this family struggling with poverty? Can they meet recommendations that are given to them? Do they have transport to get that child to therapy? Do they have resources to buy the nighttime diaper that you suggest? So you want to look at the family dynamics as well as the family stressors. Does the family need therapy and not the child? Do we need to address what's going on with mom so we can then treat what's going on with the child? You want to examine those stressors as well. Also look at the family's commitment to treatment. Is this a family that's saying, I'm here, I'm not quite sure I want to do this? Like my job right now, sometimes I'll get referrals from the therapist and patient will come to see me with the parent and they're not quite tested in medications, not quite committed to doing so. And I'll tell them, take some time to think about it. Look carefully at safety issues. Are there any safety concerns? You already mentioned age-appropriate communication. Look at the relationships, your boundaries, issues within the family. When you make plans for patients, you have to remember that the child, especially as it involves children, the child is not a standalone unit. The child is a part of a bigger unit, which is the family. So make sure you're thinking of the patient and the family when you're making your discharge plans, you're making plans of follow-up, you're making recommendations for care. Your goals should be to promote normal development, normal growth and development, and improve functioning. So sometimes you may need to do not just individual, but family therapy, activities, medication, or point them in the direction of community resources. And we have come to the end of our slides. Any questions?
How do you suggest we organize this content to kind of memorize all of these illnesses?
So for the exam, you have 2 quizzes.